Good afternoon, everyone. It's a real pleasure for me to introduce the inaugural lecture of Professor Maggie Donovan-Hall. Now, I know the phrase inaugural lecture can sound a bit formal, but in truth, these are really just brilliant excuses to celebrate someone who's been doing outstanding things for years and now being given a microphone and a captive audience to entertain us. And speaking for myself, this is an inaugural that I have been really looking forward to. Maggie is one of those rare academics who brings together psychology, engineering, healthcare, and human experience. And somehow she makes it all make sense. Her work is about connections in many ways, connecting disciplines, connecting people, and most importantly, connecting research to real-world impact. Maggie first developed an interest in academia when she undertook her BSc in psychology at Nottingham Trent University, but it was when she came to the University of Southampton to study an MSc in health psychology, which she completed in 1999, followed by her PhD, which she completed in 2006, and then subsequently in her first substantive post in the School of Health Sciences, that her hunger for research really took off. Through her early postgraduate years, Maggie developed her expertise in rehabilitative psychology and a passion for applying that to prosthetics and orthotics, using creative and person-centered approaches to ensure that the voices of people living with limb loss are not just heard, but embedded in the very fabric of the research, the new technology, or the service development. This approach has been essential in her research aimed at improving access to P&O devices in low-resource settings by recognising that the voices say and value different things in different cultures, and building this into technology design and in-country service initiatives is so vital for impact and sustainability. More specifically, Maggie was a co-founder of the People-Powered Prosthetics Research Group, an interdisciplinary initiative that brings together engineers, clinicians, researchers, and individuals with lived experience. And with her influence, this group has become a beacon of co-designed, person-centered research that is shaping the future of prosthetic and orthotic care. Her national and international reputation is further evidenced by her extensive collaborations with the NHS, with charities, and with industry, as well as by her impressive set of internationally excellent outputs. As many will know in this room, Maggie's academic excellence has not been limited to her research. She's also been an excellent and highly regarded educational leader, conceptualising, developing, and still leading the MSc Amputation and Prosthetics Rehabilitation Programme. This programme draws on Maggie's research exploring the physical and psychological aspects of patient care from pre-amputation to prosthetic rehabilitation. And it's a programme that fully embodies Maggie's interdisciplinary approach by bringing together researchers, educators, and clinicians to provide an excellent learning environment grounded in her own cutting-edge research and that of her collaborators, and is nationally and internationally renowned. Maggie's work exemplifies the very best of what we value at Southampton: research that is innovative and inclusive, education that is globally relevant and person-centered, and leadership that is both strategic, supportive, and deeply compassionate. It is my great honour to introduce to you our colleague, our collaborator, and now our professor.
Thank you, Jenny. Thank you so much. Oh yeah, I've got this. Thank you. Thank you for such a lovely introduction. That was really lovely. I feel like that's enough actually. No, but seriously, thank you so much, Jane. I really appreciate that. Jane and I have worked together for many years, and we've known each other a long time. I'd also like to thank Steve and the faculty for organising today. Really appreciate that. Thanks to Steph. But I would also just like to thank Michelle. Michelle's been brilliant. Her attention to detail was fantastic. Her patience with all the last-minute car parking bookings has been wonderful. So thank you very much. So yeah, big day today. So planning for today. Well, where do I start? There was lots of discussions about lots of different aspects of it. So people outside of my academic world were asking a little bit about what is an inaugural? What's this about? Why I've had this email, Mags? And when I actually thought about it and we were chatting to them and explaining what it was and that they had to potentially sit through maybe not one, but 2 50-minute presentations about research and other things, I realised that the majority of my friends, who I love very much, were much happier about it when the pub was mentioned at the end. There was also the discussion of what type of inaugural are you doing? Are you going to do one that focuses on your research and looks at a specific topic area, or are you going to do more of a story and more of a journey? What values are you going to talk about? Kathy and I had a chat about what values do you want to bring? What's the focus? What are the main messages you want to get across? And most importantly, and again from my lovely friends, what are you going to wear? So it's always had to be that story approach. And it's had to be that story approach and that journey for lots of different reasons. The values of patient-centred and user-led engagement, Jane's talked about that already. I've had the privilege in my research career of speaking to so many people about their stories, hearing so many important things that have enabled us to hopefully try to carry out research and implementation into clinical practice. That's really, really important. So stories are really important. It had to be that story approach to illustrate all of the different interdisciplinary collaborations that we've had. And so working together to design better healthcare technologies and services. And what I want to do today is reflect on so many inspirational people across my different worlds. So it's lots of different aspects. And it's quite apt that I have got thinking about worlds and different worlds in my title, because there are so many people from different aspects of my life here today. And as Jane said, I'm going to share that other side of the story as well and talk about my passion for research-led and person-centred education and what we've hoped to do a lot on that side of it as well. Well, where does the story start? So when I started planning for today and talking about it, I thought, well, the story starts with the first project, doesn't it? That will be the starting point. But when I actually thought about it, it was a slightly earlier influence than that. So I'm sorry, Elaine, but back to the 1970s. So it's sort of like in the late 1970s, my mum and my dad, and actually some neighbours in our street, decided to boost their income by having English language students. So we had a lovely student from Austria called Irene, and we'll remember Irene, Elaine. And then we also our neighbours had a student as well from Germany, so it was great. It was this really, really fantastic environment. And Irene didn't just come to us once. She came to us 2 or 3 summers in a row to improve her English, but we just joined such a connection with the families. And this is Irene's mum, Marguerite, and her dad, Johan. And my dad saved up, and when I was about 8 or possibly 9, we went to Austria for a holiday. And I was a curious child, and I had a very kind teacher because I became quite obsessed with Johan's prosthetics. So when we went to his house, and I would ask lots of questions, and I was really intrigued by the fact that he had so many different task-specific devices. So he showed me the prosthetics he used when he was cutting wood, driving a car, skiing, and my dad and I asked lots of questions as well. And so I kind of forgot about this, and later on you'll see when I started my first project in prosthetics, my lovely dad always felt that was the starting point. And I was a curious child, so Jane's already said, my birth name is Margaret, but actually it's only that gentleman there, my lovely dad, that calls me Margaret, call me Margaret. But let's play Where's Margaret now? Let's play a little game to start off this afternoon. So I was a curious child, there I am. Feet in the fountain, distracting Johan. He's most probably trying to stop me jumping in, but my lovely dad's just looking at the camera, looking nice and handsome. So that was an important starting point. And now I'd like to say that I was this child genius that was inspired there at the age of 8 and went on to do fantastic prosthetics and things like that, or had this really straightforward career. And my lovely friends that have known me from my childhood, Sue from 7, Lou and Kelly from 12, will know it was not that straightforward journey. And what I like to call a 7-year gap year from education. But it wasn't quite a gap year because there wasn't really the focus. And other people have said that maybe I had a lot of dead-end jobs and things like that. But for me, every experience you do has transitional skills and is a learning experience. But I started nannying and au pairing, and this was me in America with the children I looked after. And so I spent a little bit of time not quite knowing my focus, and then I came back from America with the understanding that I wanted to focus down, and I wanted to do something new. And I came to the game-changing moment of my life when I started looking after Becca and met the Still family. And they're all here today, which is fantastic. And it was thanks to Becca and the Still family that I actually started thinking about what I wanted to do. So I learned a lot from Becca. I learned a lot about disability. I learned a lot about listening. I learned a lot about really focusing on what's important for the individual. I was in this inspirational environment. Carol had recently finished her teaching degree, and she was such a brilliant role model. She had done her access course, done her teaching degree, and was starting her career as an early years teacher. And the support and environment I had, the support and encouragement I had in that environment helped me return back to education. And so I was in this environment where enabled me to really truly recognise what interests me, and that was my love for the ologies. So I went back to Eastleigh College and I started psychology, I started looking at some sociology, I went back to biological basis of behaviour, and that was a fantastic point. And then in 1996 there was this big year of change. Becca left Rose Road and she went to Douglas Arthur. I started looking after her part-time. I bought my first little flat, which was an important point. I got my A-level results. And then in September, I started doing my psychology degree. And I was really nervous, but excited. But then I met this person who's been a massive inspiration on my life, who is not here today because she's on holiday. And if anybody knows Wendy, they know that that's quite true. So Wendy and I, we actually went to, it was called at the time Southampton Institute. It was still at university, but Jane is quite right. When I went there at the time, when it was Southampton Institute, it didn't have university status, so my degree qualification comes from the University of Trent. But it was good times, and it was working alongside Wendy made me really focused and had my fantastic study buddy. And also that year, there was a big year of change. It was a big year because I met Rob, and 29 years on, the most supportive person in my life is still part of my story. And part of that was the little blue coats came along. So Rob was a single dad, and I had the fantastic growth of Mike and Ash became part of my family. And the little blue coats have gone on and had the blue coats of their own, and we call them the blue coats because they all had matching coats at that time. And poor Ash not only had his own blue coat, but he inherited Mike's blue coat, and then I think it was the other way around actually. I think Mike was bigger than Emma, but poor Ash was in a blue coat for a long time. But they were great, and the fun we have was just absolutely amazing, and these are my tribe, these are my people. And then at the end of my psychology degree, I started to be interested in, well, I was interested in lots of different aspects of it, but some of it didn't quite fit. And it wasn't until I did an option unit in house psychology with Jackie Leckie, I started to really think, this makes more sense. I could really see the link between house psychology and rehabilitation, and started pulling together the different strands of my interests and my different experiences. And then I applied for the Masters in House Psychology. And unlike Dennis, that seemed to have lots of travel moves and lots of travel grants and lots of moves around, I went from one side to the other. I came up to Southampton, or up the road as we used to call it. And I was really lucky because when I was thinking about doing that master's course in the summer of that year, I received a really influential letter through the post. And that letter was inviting all people who were in that cohort to apply for what they called a directed master's project. So it was one that had like a studentship really, it had some money attached to it. And it was an opportunity to carry out this psychosocial project looking at the appearance of prosthetic devices. So it was working with a private company that I still work with today, Dorset Orthopedics and also Bob Watts. And this was a fantastic opportunity because my project was supervised by Lucy Yardley. And Lucy and I worked on this project together, it was quite complex. We designed some surveys to look at the engagement activities revealing your body, but we also recruited people and looked at the difference between people's their confidence in revealing their body before and after having what you would look at as a more realistic looking cosmesis cover. And it's been great. So I've worked in this field for quite a long time. And what I've noticed is how the difference in the reactions and the confidence in people in terms of revealing their body with a prosthesis and how things have really, really changed, which I'll talk about a little bit later. And then during that time, there were some further opportunities that came along just straight after my master's degree. So I had the opportunity to apply for a combined research post and a PhD and a part-time PhD. And this was in an area of vestibular rehabilitation. It was working with Lucy. I think it was Lucy's first big trial at the time, actually. And what I did was I worked for 3 days a week running the randomised control trial, which was fantastic learning opportunity. And vestibular rehabilitation is this graded set of exercises involving eye, head and body movements to restrain the vestibular system. So it involves things like this, and then you would progress to do it with your eyes closed. And so it was a big complex trial, and there was a lot of trust in somebody straight out of their masters to run it. But it was a fantastic opportunity. I learned so much. So we had 170 people on the trial, and everybody was carried out a baseline assessment. And so I would go around. It was carried out in their homes with my balance performance monitor and my big pack of questionnaires, and asking people, going through the assessments. And then I would go back, then they would be randomised into the vestibular rehabilitation group or normal care. And then I would go back at 3 months, and it was supposed to be a single blind project. And I learned a lot about trying to get people not to unblind the project. So the conversations would be, you'd phone them up and, right, remember I'm coming round? Yes, I'm coming round. You're the dizzy lady? Yes, I'm the dizzy lady. I'm coming round. It's got to, you not to tell me which group you were in. Okay. So that means if you've been given the leaflet, can you not have it on your living room side, because then I'll know, and things like that. And Lucy and I would have lots of conversations because my list of participants who became unblinded was getting a little bit larger sometimes, so we had to think of strategies to stop that. And then I'd go back and see, because it was a crossover design, some people who were in the control, or everybody in the control group then went over into the to the vestibular rehabilitation group, so I'd see them again. So some folks I got to see 3 times in the study. And then my PhD was carried out part-time, and it was looking at adherence to, factors that influence people's adherence to the exercises, which was really, really important. So I used a psychological model to help me do that. And in addition to that, I had a research post working with Brona Walsh, because it was nurse-delivered vestibular rehabilitation, and we interviewed all of the nurses who took part in the trial to find out their experiences, and that was really helpful as well. And then I carried on in psychology, being a researcher, and so I was still doing my PhD because it was part-time even when the project had finished. And I worked on another project, on a couple of other projects with Lucy, and this one was a really important one. It was quite a large network. It was called the Prevention of Falls Network Europe, and this was established to promote good practice and in effective falls prevention across Europe. So lots of collaborations, and a lot of the work we did, and see Fliss was on that project, Fliss is here, Fliss was, we looked at fear of falling, the psychosocial aspect related to falls, which was really good and really important for future work as well. And I also worked on a project called a project funded by Help the Aged. And at the time, Help the Aged were producing some leaflets, and they were concerned that the leaflets didn't have quite the right messages about falling in them. So we carried out a large qualitative project with over 60 people taking part in interviews and focus groups. And it's called, the leaflet that we ended up producing that Help the Aged disseminated was called Don't Mention the F Word. And this was because one of the main messages that came out of that study was people, when you talked about falls prevention, when you presented it that way, it impacted on people's identity. But if you reframed it and you talked about it as prevention of falls, if you talked about it as maintaining balance and maintaining healthy living or active living, then those messages were much more accepted. And this was, the work I did in psychology and my research posts were fantastic training opportunities across all of the projects. There were so many transferable skills. I learned so much from that. But at the time, you get to the point where you're on one short-term contract after the other, and you want to think a little bit differently. And then at the time, I was doing a little bit of teaching in the School of Health Sciences. And so I had the not-so-big move, literally, from one side of the campus, unlike Dennis, with all this, to the other side. So in 2004, as Jane said, I started my lecturing post in psychology, my lecturing post in health sciences, which was fantastic. And at the time, we were all based in Building 45, which is now a building site, being knocked down. But at the time, we were the School of Health Professions and Rehabilitation Sciences, and later we became the School of Health Sciences, and we joined with nursing and moved to Building 65, which is literally a minute away, so I haven't moved very far at all. And when I moved over to health sciences, I really had a natural fit there. I was welcomed very much by the OT team. Bernadette's brought me into the OT fold right from day one. I had fantastic colleagues, lovely JP. I felt really, really welcomed. And what was really important was Bernadette always reflects back on the fact that she said she fought for me. She looked at my CV and I'd met her a couple of times, but not very much. And she said she wanted me to come into the OT team because she really recognised the synergies between OT and psychology and the kind of work I've been doing and the falls prevention work. And that was and as well as a vestibular rehabilitation and that sort of like very good training I had working with Lucy for so long. And that was so true. I did fit in really, really well. And I worked on, I was given a teaching load straight away, working with lovely Jo Adams on the research side of things, and later Pete White, and the three of us revamped all of the research methods across all of the programs. So it was across OT, physiotherapy and podiatry, and a large number of students, 170 students, and we came up with all of these different ways that we could teach research methods in an interesting way, with like research triads and things like that. And at the time, everybody did individual project, and we, days and days sat on the ethics committee going through all these projects. But I also worked with Lee Price, and he took me under his wing, and we revamped all of the psychosocial aspects within the all of the programs, all three of them, and I led that for a little while as well. So that was great. It was a really, really great team and great students. And during that time, I was invited to join the Inspire Foundation, which is a charity focused on funding research for people with spinal cord injury. And I met Jane. And this was great. This was a really good opportunity because I think I'd finished my PhD. But the work that Jane was doing at the time, she recognised the need to understand perspectives on the current and future use of functional electrical stimulation for people with spinal cord injury. So Jane had been planning this project and talking about it, and it just fitted. Jane and I had a conversation, the qualitative background, and I worked on this project with Jane. And it was just for those, functional electrical stimulation uses low-level electrical currents to help restore or improve functions, and that might be standing or grasping and things like that. And this project in spinal cord injury was looking at all different types of FES devices. And what we did is we conducted a relatively large focus group study with 8 different focus groups. So a focus group is bringing a group of people together, and you're asking them questions, and you're looking at the different experience and perspectives, and you're running it in the way that you can tease out when people are thinking of things in a similar way, or maybe where there's differences and things like that. So we conducted those focus groups across all spinal cord injuries, across all spinal cord injury centres, and it involved quite a lot of travelling around and doing that fantastic work. And then, although we had what you would call a relatively large qualitative study, because we had quite a number of different focus groups with both people with spinal cord injury and healthcare professionals and researchers in the field, we needed to explore the extent to which these beliefs are held by the wider spinal cord community. So Lisa joined the team. Lisa Tedesco-Trickers, she joined the team as a researcher. And what we did is we took all of those perspectives and views and experiences that we had gathered in the focus groups, and we created a nationwide online and paper-based study. And this was the first one of its time, and what we wanted to do is we wanted to we wanted to design a study that enables us to find out these views. But what we wanted to do is use this to influence clinical practice. And so we could see what was important to continue with and maybe make some changes and look at the access to FES devices for people with spinal cord injury. And we worked hard on that survey, Lisa, all of us as a team, and we produced something that we're proud to say has been picked up and used at an international level. And so recently, a team in Australia and New Zealand have come together, and they've used our scale to do the same. They've used our survey to explore the barriers and benefits of functional electrical stimulation in these settings as well. And somebody else has been in contact since that's been published to say they want to do the same in South Africa. So this relatively little charity-based project in the grand scheme of things has done something quite important. And these papers are cited quite a lot. And then, although the work in spinal cord injuries focused on the use of lots of different FES devices, I then had the opportunity to work with Paul Taylor, fantastic bioengineer, on a project taking one specific FES device, which is the drop foot stimulator. So the drop foot stimulator addresses drop foot when people in lots of different areas, and there'd been lots of studies in the past to show that it had been used in multiple sclerosis and stroke. And what Paul wanted to do is build up on the small body of research that he had been doing to look at the use of it to help people with Parkinson's disease. And so this was a really important, this is still an ongoing body of program of research, but this was really important because FES for Parkinson's disease, or the drop foot stimulator for Parkinson's disease, is not available on the NHS, but it is available on the NHS for other conditions. And for it to become available on the NHS, you need research to underpin it. And at that time, there were some small studies. So this support to try to get NHS adoption was something that resonated with me, and was really something that I could possibly help with in terms of embedding the qualitative research within these trials. So Paul and I and a team of other people, we got funding initially for a pragmatic two-site feasibility study. So this was, again, where people were put into two different groups to look at the use of FES for people with Parkinson's disease, so to help with that drop foot and that mobility and walking, so using measures such as 6-minute walk test and other things. But what we wanted to do is explore, because it was a feasibility study, not only explore the impact of FES, but we also wanted to find out how we could design a better multi-site study. And so the embedded qualitative research focused on both of those different aspects. And what we did was we took a couple of times, to be honest, but we got there in the end, and were the first multi-site study of FES for Parkinson's disease with 8 centres. And it's a big trial. And we finished the results for that in 2027, and hopefully that will lead to the NHS adoption that we've been talking about. So it illustrates that iterative process of patient-public engagement involvement, so involving people in the design of these studies so that they're fit for purpose and they work in a really good way, but also that embedded qualitative research, so understanding what it's like. So we might get the numbers about people, if it does improve walking and things like that, but what does that actually mean to somebody? So what does that actually mean? Well, it could mean, is walking faster important to you if you have Parkinson's disease? Is that the right measure to look at? And things like that. And with this research, I've been overwhelmed by how much this device, so this device can actually have an impact on everybody's life. We've had stories about how people have grown in self-confidence to go to the shops by themselves for the first time. They can pick up their grandchildren from school because they've got confidence in walking. They're able to go out with their husband for the first time and not necessarily being trailing behind, and actually can keep up, and all sorts of different aspects. But at the same time of this, I've had this ongoing commitment to prosthetic research. So in parallel to this, I was working with Cheryl Metcalf, and we were strengthening our research and collaborations within prosthetic rehabilitation. So we secured some money for a PhD funding, and we had Tara Sims, she came to work with us, and we carried out a series of different projects looking at children's perspectives of upper limb technology. And this was an important starting point for me, because we started to use some iterative methods of user-led design. So this was my first study within this area. And what we started to do is what we did was we had focus groups with children, and they told us what they wanted out of an upper limb prosthetic. And we used 3D printing to make those prototypes and bring them back to the children so they could show us their views and their appearance, their views and their opinions on those devices. And as we've been doing this, we've always recognised, as Jane talked about, the importance of those great clinical partnerships. So Chantal, got to have a picture of you. Chantal and I have been working together for many, many years, and we actually met when Chantal was doing her master's project, and that I was involved in with Caroline Ellis-Hale. And this was a really important collaborative relationship, and it enabled us to, support clinicians doing research, but also really try to understand the real-world clinical issues that we should be researching. And this also broadened, Chantal got me involved with BACPA, with the British Association of Chartered Physiotherapists and Limb Absence Rehabilitation, and also, which was fantastic. So I became a member and then a committee member of that. and recognising how it was important to build those reciprocal support and capacity building relationships in both directions. And talk through these clinical partnerships, we recognised, and through our work that we had done before with children with upper limb difference, that we recognised that was very little support for children who are living with limb difference. And so they may be the only person in their school who has limb difference. So what we've done for many years, we had to stop for a little bit of time, but we started again, is I'm a volunteer, and we go down, we run a children's friendship group on a Saturday morning 4 times a year. And that's been really, really important. And all the children are in this castle we built, but I've obviously had to cover up their faces. And I think at this point I had a bit of a light bulb moment, or maybe not then, but over a period of time I started to realise that what I wanted to do was really champion user-centred assisted research. And it was through lots of different conversations, and particularly with Jane, who was my research lead at the time, and my research mentor, that it was important what we were trying to do in terms of the value of interdisciplinary research and assistive technology, and recognising how my background as a health psychologist and my commitment to those pragmatic use of flexible research, using the tools that are needed for that particular question, was what that could contribute. And it also acknowledged that there was this change in landscape and growing importance of user-led and patient-centred engagement. There was times with, at the time, the EPSRC and other types of funding committees were really putting quite a lot of focus on this. And then I was somebody that maybe could help with this within larger projects as well. And then working in health sciences really gave me that opportunity to work in this interdisciplinary way with so many different people and have these strong internal, external collaborations and ensure that the end user's voice is heard in the real world context. And I think some of the inspirational quotes that have really helped me is this one. So this one goes back to 2004, but I think Pamela Gallagher here has said something that really resonated with the kind of research I wanted to do. So this was at a time when there was a growth in microprocessor knees, multi-articulating upper limb prosthetics. And what she's saying here is to capitalise on that current rate of advancement and development of prosthesis, and to gain that greater understanding, we need to attend not only to the physical and technological factors which play a fundamental role, but also those social and psychosocial issues. So really understanding that lived experience. And I'll introduce Alex a little bit later. But Alex and I, we stumbled across this when we were starting to do some work together. And this has become a little bit of a mantra for our research that I'll be talking about in a moment. But how many technologies and scientific interventions continue to fail for a lack of understanding of that social, cultural and historical context and their likely reception by the people and the societies they are intended to benefit. So I take a less linear route now, and I talk about things as a little bit of a whole. But what we were doing here is working with lots of different groups of people. We started to create our People Paraprosthetics group. So an interdisciplinary group of people coming from lots of different backgrounds, and we sit as a research theme within the Acting Living Research Group, which I co-lead with Kathy Bowen. And Kathy Bowen's been really helpful in trying to develop that theme, but also our wider Active Living Research Group and how we're trying to look at this in a way where we're growing these different themes of research within this overall umbrella. So that's been really great. So clinicians, prosthetic wearers, academics, engineers and students were coming together as a group and trying to do research, which is important. So the commitment to improving prosthetic rehabilitation services and the lives of people living with limb loss. So to do that, what we need to do is root it in real-world practice. We need to deliver sustainable solutions shaped by the forces of key stakeholders, so thinking about those interviews and focus groups that I've been talking about, as well as lots of other practical methods. It needs to be person-centred. It needs to be person-centred and impact on what truly matters. And in order to do that, in order to understand what truly matters, we need really important patient-public involvement and engagement. So we need to know what people want from research. We need to co-design it, everything that we do. And what we're thinking about is we're thinking about that equity focus. We're thinking about exploring and tackling both national and global inequalities in access to prosthetic services. And we're driven by our collaboration and diversity, so that interdisciplinary approach, bringing all those different professional groups together and bringing our experience across disciplines, sectors and communities. So I'm going to briefly take us through some of the projects that we've been doing with our People Prosthetics group. And this isn't exhaustive at all. We've got lots of fantastic work, and this is just to highlight a few. And what I'm going to do is I'm going to focus on that person-centred at the core, really think about some of the user-led design and sort of like the more qualitative parts that I've had involvement in, as well as talking about the project and the interdisciplinary focus. So meaningful outcome domains and the use of data. So Chantal has carried out some fantastic PhD work. She is a machine, balances so many different roles, and her Me Amputee study came. We came up with the idea on a drive back from a conference, from a backpark conference, and we came up with this idea that we really need to really explore meaningful outcome domains of recovery for people who have a lower limb amputation. And what Chantal did is she did a series of fantastic studies supervised by Alex and by Cheryl, so we're bringing the team back together. And we looked at a series of user-centred studies leading to the development of Chantal's fantastic Eclipse model. And you might not be able to see very well, but because it's been developed on this qualitative research, the statements around what people actually want, what's meaningful for them and what they want at the end of their prosthetic rehabilitations is a series of different statements. I want to be able to participate in my important activities. I can participate in my important activities in a way that I want to. My prosthesis works for me. If I'm able to plan, I'm able to manage it. And in all of this was the overarching theme of then you're able to accept my new normal. And you can have a look at this because it's fantastic published work. So what it provided was this holistic understanding of showing that important outcomes go far beyond simply walking. And it's like guiding clinical practice, policy and future research. And all of the publications that underpin this. So really, really fantastic work. But whilst Chantal was doing this, not only having 3 different jobs, doing a PhD by publication at the part-time, but within 4 years, Chantal also started developing her own programme of research. And so you move towards this sort of like patient-centred data for transforming prosthetic rehabilitation. So while she was doing her PhD, she wanted to apply for a research for patient benefit grant. And why not? It's Chantal. And so, even though I've called it postdoctoral work here, she did apply for it when she was coming towards the end of her PhD. And what we found out at the time was the ideas around really understanding what this sort of like what would a patient-centred data environment look like? How could we use routine collected clinical outcome measures in a way that could support people's rehabilitation, people's care from a patient-centred perspective. We noticed that we found out along the way that somebody else was not quite thinking along the same lines, but had some similar interests. So we brought Cleveland Barnett into the fold. I met Cleveland at a conference, and we'd never met before, and it was it was quite funny. So we're texting each other, and we planned to have this meeting. And I said to him, it was OT World, and Otterbock, who were a leading company in prosthetic rehabilitation, had literally about a 30-foot prosthetic leg at the middle of the conference. So I'm saying, I'll meet you by the sea leg. And he thought I'd gone mad. And then when he walked into the conference room, he could see this huge prosthetic leg. And he was like, yeah, that's where she is. So, and then we've brought our team together, and within that team, we've got faces that I've already talked about, Professor Alex Dickinson and Cheryl, but we've also had our, brought in and had the luck of having the most fantastic researcher, Lisa, who's joined this team. And so this is very much about taking a patient-centered approach to understand those views and perspectives on what this data-driven care environment would look like. And so I'm picking those different aspects of it. What do people want as a minimum data set? What's the meaningful outcome measurement? The effective data collection practice, the improvement and impact on partnerships, as well as thinking about the potential of electronic data capture systems. And so what we've tried to do is we've tried to do this in an iterative, patient-centered approach. So we've started off with a scoping review of existing patient-centered data collection initiatives. So what can we learn from what's already out there? Moving on to large-scale qualitative studies where we're interviewing clinicians and carrying out focus groups with patients, clinicians, and wider stakeholders. And then moving on to that national online survey. And then this is what we're doing at the moment, is we're carrying out a series of workshops where we're taking all of the findings from this and we're working with people to create some recommendations for a patient-centered data collection. And to do this, we need to use flexible, user-centered in those iterative stages of pragmatic research. And then I'm going to quickly talk about some research we've done enhancing the prosthetic socket fit. Because the socket, which is the interface between the residual limb and the prosthetic device, is the most important aspect. We've already talked about advances in prosthetic technology, microprocessor knees, and things like that. But if you don't get the socket right, it can lead to people ultimately being in pain, not being able to do their activities of daily living, and maybe, in lots of cases, not using their prosthesis. And we know from other research that people can go back to their limb centre up to 9 times in the first year, or 9 times a year, due to socket comfort. So it's really important. So what we're trying to do here is show you a series of 3 different studies which use qualitative user-led approaches in slightly different ways across the different projects. So this is research very much led by Alex, Pete Worsley and Josh Deere, who was initially one of Alex's PhD students. And traditionally, sockets are made but with plaster of Paris. And over the years, more and more CAD, so computer-assisted design and computer-assisted manufacturing has come into place. And what Alex has been doing for a long time with the others is looking at the use of these different methods. And they've been developing this AI integrated software platform for prosthetic design. So this has led to Radio Devices, which was a spin-out company from the University of Southampton, and some Innovate UK funding for this multi-clinic testing of AI-supported socket design. So some fantastic work here. And my role in this was really simple. This is quite a technical project, and as a psychologist, but my role in this was quite simple, because what they wanted to do is they wanted to know the experiences of patients being fitted with the 2 different types of primary prosthetic, the AI integrated software one and the normal scanned one, and they also wanted to know how the prosthetist felt about it as well. So my job was to work with the team, teach them qualitative research, work together, come up with some really appropriate ways of doing this. So working with the team and finding the right fit of those methods, and that was absolutely fantastic. And then using this sort of like iterative approach in a slightly different way. From the back of that study, we've also noticed that, well, we also know that feedback, communication about your socket can be really, really different. So feedback from our public patient and involvement activities with individuals with lower limb loss told us that communication about any problems they have with their socket is really, really important. They experience ongoing discomfort with that, and explaining this discomfort, explaining the nuances of that can be really, really difficult, and especially if you're in a really short fitting appointment. And so, and also that, you know, it can change throughout the day. It might be quite comfortable in the beginning, but different aspects of your everyday life is going to impact on that level of comfort. And what they wanted, this came from patients, it didn't come from us. What they wanted was they wanted a way of managing that, of recording. They wanted an idea for that self-management and communication app, so an app on their telephone that they could use to capture their socket comfort experiences throughout the day. So we led to this project, which was co-designing a digital app with individuals with limb loss and clinicians to support that communication. And so this could be really helpful. It could lead to that real-time monitoring, so people could capture that as they went along. It could enable users to log residual limb changes. It could provide clear, actionable data for the prosthetists, so they could really find out what's going on for individuals. And that could ultimately lead to better socket comfort outcomes, fewer adjustments, and these things here. So we wanted to develop this digital app in partnership and work together to do that. So again, this iterative process of user-led design. So we based this on the principles of participation action research that we're using in other projects. And we went through these different rounds of this co-design and development. And I'm going to talk through this now, and I know I was probably a bit short for time, so I'm going to talk through this now. So this very first round is about understanding what the issue is. So exploring those socket comfort experiences and identify those user requirements. So it needed to come from the people that are living this every day. But we also we had two different groups. We had people who are living with lower limb loss and using prosthetic devices, and we had the clinicians and the healthcare professionals who are trying to tackle these issues on a daily basis. And we carried out focus groups, and we came up with lots of different themes and a lot of research that we then tried to take back and move on to cycle 2. So we analysed, at the end of cycle 1, we analysed all of that data, and we produced this user requirements report. So we presented the user requirements report in a second round of focus groups, and we asked people to feedback on these visual blueprints or skeletal outlines of what the app might look like. So we showed it to them within the focus groups, and we used all of their feedback to take it on to the next level. So they asked us we asked them about the layout, we asked them about the functionality of the app before before we came up with a much more detailed design. And then moving from that second cycle, so moving from having it as the blueprints to actually having it as something that is much more of a web-based prototype of what an app might look like. So we took all of that feedback from the second round, and then we produced this minimal viable product that we could show people what it looked like on a web-based prototype. And then we moved from focus group discussions to one-to-one cognitive interviewing. So what we used a technique where we met with people online, and they logged into the website, and they started to work their way and click their way through the app. And we used cognitive interviewing, which is basically, back in the day in psychology, it was just called think aloud. So we got people to just tell us what they thought about it, and we asked probing questions so we could make it better. And then we took that, and we ended up with our end point was the prototype. And now we're working on funding to take that forward. So you can see how you've got that iterative process of user-led design. And finally, within this aspect, I want to quickly talk about some other research we're doing, where we're trying to understand that lived experience of socket comfort a little bit more. And what we can see across, although it's a really, really important issue, and I think hopefully I've shown that, but what we know here is there's current evidence is based on surveys and quantitative measures, and there's very little actually understanding the lived experience and the person's voice underpinning it. So what we wanted to do is we wanted to really to understand this, and so it was a relatively small project. We got some internal funding. But recognising how important communication about socket comfort is, Lisa Roberts joined the team, and Hayley Freeman was our researcher on this project. So Lisa's expertise and knowledge about communication was fundamental for this project, and we're really thankful for that. And so what we wanted to do is we carried out a large number of interviews to really explore people's everyday experience of socket comfort. And just to illustrate how this is sort of like built up, this is just the research relating to the patients, but we also interviewed healthcare professionals. But we could really start to understand the quality of communication provided is important, and what factors were influential in that. We also understood stories about being listened to and how important that was, and feeling heard, and it was that two-way process. And and how people could feel really frustrated when they didn't feel that their voice was heard about their socket comfort. And that quality of that therapeutic relationship being really, really important. And that impact, and what the impact of poor communication has. That impact on poor patient experience, blame, pushing for new componentry, and those different aspects. So it enabled us to build up a picture of what's important. And we also interviewed healthcare professionals. And so finally, I just wanted to flag up, when I'm talking about the research, is the research we've done in low resource settings. And this has been really important because I've concentrated very much on the UK here, but when we're thinking about people living with limb loss, we know that the majority of people live in low resource settings. And that's really important. So, for example, approximately 2/3 of people with upper limb loss live in low resource settings. And a number of people, it's been estimated that 80-90% of people don't have access to prosthetic or orthotic devices. And there's been so much advancement in digital technology and things that we've already talked about today, as well as lots of other types of research. But there's always been this view across different groups that possible digital technology and engineering may help expand access to prosthetic rehabilitation in these low resource settings. But to do that, again, it goes back to that importance of understanding that context through user-led and co-design research. And if you don't do this, you could do unintentional harm. And so by doing it well, you're preventing that unintentional harm, you're by avoiding inappropriate or unsustainable approaches. And you've got that increase of that meaningful impact and long-term sustainability. And then you've got that, also if you're listening to people and hearing what the problems are, you're increasing your impact of doing that addressing real-world problems. So it's avoid those imposing predetermined projects or solutions by working in partnership. So I was lucky enough to work on, well, not lucky, worked hard to secure 2 grants in this area in a very important call. It was the Global Challenges Research Grants call. And what the key contributions were, that sort of like underpinning that exploratory and scoping work, using the approaches I've already talked about today, and that collaborative working and that importance of understanding the lived experience. So the first project was led by Alex, and there's a programme of research upon the potential use of data technologies to increase P&O services in Cambodia. And the second project was working with Lawrence Kenny, and it was looking at developing a fit-for-purpose, affordable body power prosthetic project based in Uganda, and working with colleagues in Jordan as well. So what's key for this work, and what I've already talked about, is if you're wanting to really ensure that you're doing something fit for purpose and you're really understanding the problems is this sort of like scoping visits and field work, that informal scoping discussion with multiple stakeholders, tailoring your approaches and training, and that flexible qualitative research to really understand what those lived experiences are. And so in both projects, we carried out lots of scoping and field work. We used an ethnographic, so basically we used a framework that helped us really understand that cultural setting. So we gained insights into that sort of like social and cultural factors that were important. And we went through this process ourselves of cultural training. We put to the side any predetermined ideas of what might be helpful and really started to listen. And these observational visits were really important to provide that context and identify those key considerations. And what we did in both projects is we built that sort of like supportive team. So in the project in Cambodia, the use of pump priming funding for I4S was really fundamentally important. So if we didn't have that initial small piece of project, we would never have come up with, we would never have identified what was really important. And those initial visits helped us do that. So that opportunity to really listen. And with the second project, it was really, really important to visit the hospitals and to visit those different, and really understand the manufacturing and supply chain was particularly important for this project. So whereas in Cambodia, they already had some quite, where they had very, very developed systems, and it was looking at how we could maybe increase that access. But within Cambodia, we were trying to look at the development of something new, looking at the development of a fit-for-purpose upper limb prosthetic. So it had quite a different focus. And so this initial work was a fundamental part of that. And then those informal scoping discussions as well, sort of like building those collaborative relationships. Again, those visits to factories, to, looking at the feasibility of social and cultural insights, discussions with clients was a part of it. In Project 2, we met with the International Committee for the Red Cross Managers and had lots of different meetings around things like that. So we're really understanding what was important. And then we noticed in some of our, it became quite obvious talking to the groups, and we also noticed in some of our initial pump priming research that it was really important that we worked with local teams of researchers, and we used these opportunities to capacity build. And so within Project 1, we had 2 local researchers, backgrounds in social work. So we happened to think about ways that were new to research, that we could come up with flexible training packages and things like that, so that we could enable them to carry out the research, and we worked alongside them. Because of us carrying out the research, of those cultural nuances, and that were really important. And then within Project 2, the project was linked to the university, and so when we were deciding to carry out some of this training, we were asked to do this at a wider level and invite PhD students who were doing degrees at the university to come along. So it became something much different and much bigger. And when we carried out Project 2, what we realised quite quickly was the assumption of one researcher carrying out the research wouldn't work, and we needed a team of researchers because of those cultural preferences on who you would want to talk to about your issue, about your limb loss. And then we had the final, we carried out this embedded qualitative research in both studies. So, really trying to understand that lived experience in different ways and finding out what was important. So I've mentioned a few people here, but they were big teams of research when this low resource setting work, and we built our teams over the years, and we're doing lots of other projects here, and I was just focusing on those as examples, and our team and our connections are building, which is fantastic. And yeah, and hopefully our impact is building as well. So finally, I just wanted to go back to what Jane was talking about before. Not only have I had a role in research and education, I've also passionate about education, and being on a balanced pathway means that I have this key academic role. And in 2004, I was really lucky to have the opportunity to merge my amputation research with my education delivery. And it was then BACPAR, who I've already talked about, issued a call to all physio departments for expressions of interest in developing an MSc programme and continue professional development, CPD opportunities for people who were working in the field. And I was supported by Rich Collier at the time to put together a proposal, and I was in a good position to do that because I had a fantastic network of researchers, clinical colleagues. I could sit down and talk to people, and I can draw because I'd been involved in the field for quite a while, I could draw on lessons learned from previous CPD delivery and really listen to what stakeholders wanted to create this bespoke programme tailored to their needs. And so we did that. We were able to develop the first MSc programme in amputation and prosthetic rehabilitation. It's quite a focused master's, and it works because it only involves 2 core modules in amputation, rehabilitation and prosthetic use, and the second module in contemporary issues with limb loss. And it's been a fantastic way of drawing together the community and offering these opportunities. And we're 10 years on now. We've just celebrated our 10th birthday. So we've had our 10th cohort of students. We've noticed that flexibility and efficiency are key to the sustainability of this focused programme. We have to do this in a really flexible way. So we were quite brave how we decided that it's only going to work if we teach in teaching blocks. So for the modules I showed you just now, so for these modules here, we teach these Thursday to Sunday in blocks 3 times a year. So that was something a little bit different at the time. But if we didn't do that, although we're growing our international reach, if we didn't do that, busy clinicians working in the NHS would not be able to attend our courses. And by listening to our stakeholders and asking what they wanted, they said they wanted to do this. So that's really important. And I'm delighted to say that this year we also secured our first Commonwealth scholarship. So looping things together and going back to the point that the majority of people with limb loss live in low resource settings, this is really, really important. And this has led to being, not just this, but the research as a whole has led to being involved in being one of 4 partners in the first doctoral training programme, prosthetics and orthotics. And this has been fantastic as well, and it's given me an opportunity to work with some fantastic people and across these 4 different institutions. So, bringing the story to an end. Now, I'd like to say that the academic and their team lived happily ever after. I'd like to say that our grant applications were funded for the first time ever, and their papers received glowing reviewers' feedbacks and no reviewer-free insight. We know that's not true. And the student numbers were never-ending and all these kind of things. But that's not my academic career. So I'd like to finish, and I must probably run over a little bit anyway, but just thanking everybody for being part of my story and for all your amazing support and inspiration over the years. From my family, my friends, Mr. Donovan in particular, it's been brilliant, and also this this approach, this interdisciplinary working, has been amazing, and could not have done it with everybody that I've worked with along the way. So thank you very much.
I don't know if this is working. Is this working? It is working. Well, thank you very much. That was absolutely fantastic. It's so amazing to listen to you tell it as a story, and gives hopefully everybody here that didn't know it already a real insight into the amazing work that you've done. So thank you so much for that. Are we allowed a little bit of time? We've got time. We've got 2 or 3 questions. Anyone got any questions out there? Do I run around with this, or do you?
Oh, sorry. Oh, she'll be able to hear me. Oh, right, okay. I was quite interested in what you had to say about the cultural differences. Now, is that down to sort of the research that you do, or is that down to sort of like the practicality of use of the prosthetics themselves?
I think it's down to lots of different factors.
Yeah.
We've seen lots of different social and cultural aspects, things being fit for purpose. So, for example, implementing technology in different settings, thinking about terrain, thinking about the use, thinking about those different aspects are really important. But some of those social and cultural aspects relate to how people want to use their prosthetics. So, for in some settings, the importance of being able to kneel down, for example. And those different aspects, being able to sit cross-legged, for example, when people are eating, or different aspects relating to that. So I think the message there is listening, and is really trying to explore those social and cultural differences. And what we talk about quite a lot is not taking technology straight into settings, or looking at that without really understanding that. I want to draw on my lovely colleagues that have done that with me as well, but I think that's the importance, isn't it? And Alex and I learnt that in the Cambodia project. We had I was listening to Alex talking about lots of different technologies, and he was listening to me thinking about ways that we could maybe explore how this worked. And I think it was a real partnership with, when we went out there with Pete straight away, our plans changed, didn't they? I think it was a conversation in a restaurant when we had been to various different various different factories, and talked to clinical partners and different things, that we actually realised that our initial ideas weren't going to work. And so what we were initially, so we'd gone from this small grant to this bigger grant, and if we hadn't done that work and we hadn't gone out there, we might have got the funding. You never know, because people reading the applications and giving out the money for funding don't know necessarily what's needed. But we didn't want to do that. We wanted to make a meaningful impact. So I think that's a really important question. Thank you.
Thanks. Hi, Maggie.
Hi.
Thanks, that was a great lecture. I was just interested in your reflections as an academic working in a department which is not your sort of primary discipline, and whether universities can kind of learn from your experience. Would you recommend it as an experience?
That's a brilliant question, Claire. And I wish it wasn't being recorded to answer it. No, it's a fantastic question. For me, the fit was right. I loved working in psychology, and lots of my psychology colleagues are here today. But I think it goes back to what I was interested in. It goes back to, I think quite quickly, even though I did a psychology degree, Carol, remember, at one point I was going to apply for an occupational therapy degree. We had a fantastic occupational therapist working with Becca at the time. And I had thought about it, and I had thought about that. And I can remember thinking, no, actually, it's with the psychology I'm really interested in. But when I was doing my psychology degree, there was parts of psychology that were interesting, but it just wasn't me. And then when I started to pull that together with the sort of like the rehabilitation and the disability, even in my undergraduate degree, I did a project exploring social support for parents of a child with disability. So then to go on to do my health psychology degree, but be able to concentrate on the part of health psychology, which was the rehabilitation, and other aspects of health psychology weren't as appealing to me. So the time I got to health sciences, I felt like I'd come home a little bit, being surrounded by physios, OTs, podiatrists as well, because there's lots of aspects related to that. That's really, really important. But I really did feel at home, and Bernadette supported me so much to draw out those sort of like synergies between health psychology and AHP, and I've never looked back. So thank you. Any?
We're allowed one more. I've got one.
Oh, Jane.
So you sort of left us with it may not be a happy ever after. It feels like quite a happy ever after.
Yes.
But I just wondered if the funding gods rained down on you tomorrow, what's the one question that is really burning inside you that you would really like that money to fund you investigating?
Well, I think hopefully Alex and I are working on some projects at the moment with the wider team as well, and I think it is the sort of like bigger grant that I don't know if we get or not, but hopefully we will. But it is I think we're trying to carry out some work that is really looking at those synergies and looking at what we can learn across different prosthetic and orthotic settings at a more global level. So working with teams of people in low resource settings and in more established areas of the world, and trying to come together a little bit. So I think my question would be how can we learn and work together and reduce some of these inequalities in a way. And you need big programs of research to do that and to compare data and learn from each other. So that's it. Yeah, fingers crossed. But yeah.
We'll all keep our fingers crossed.
Yeah.
I think we have to wrap it. Do I hand back to you? Are you closing? I'm done.
Thank you.
Yeah. Okay, I am going to make this as quick as I possibly can. I've got a quick couple of reflections and a couple of quick invitations as well. So the two quick reflections. I did say at the start that there would be connections running between the talks, but I didn't expect one of those connections to be the C-bomb and the F word. That's the first thing. But no, not you. Yeah. but the main reflection is this: haven't we got a couple of Maggie, Dennis, a couple of truly inspirational, fabulous colleagues? So thank you both very much indeed for your talks and your reflections on your careers and the amazing work that you've been doing across your time here at Southampton and indeed elsewhere as well. So thank you both. And then a couple of invitations. If you agree with me in that sentiment, then in a moment please do let's thank our speakers in the traditional way. And the other invitation is that the drinks and the canapes, the posh snacks, are waiting for us downstairs on level 1, so we can move down there and keep the conversation going in just a moment or so. But thank you both very, very much indeed.